Good afternoon. Welcome to the Senate Committee on Health and Human Services. Madam Secretary, please proceed to call the roll.
Senator Wynn, Senator Stone, Senator Titus, Chair Doniate.
And I am here. Please mark Senator Wynn present when she arrives. Good afternoon. Welcome everyone to today's meeting. Today we have a hearing on Senate Bill 44 and Senate Bill 118, along with the presentation from Division of Public and Behavioral Health from DHHS. I at least have a goal of getting us out within the hour, so we'll see how good we follow that. Before we start, I want to make several housekeeping announcements. The agenda items may be taken off in a different order than listed. I don't anticipate that happening today. For folks that want to participate, we ask that public comments be kept to 2 minutes so that everyone interested in speaking can be accommodated and to ensure that we can get through the agenda in a timely fashion. You may also submit public comments in writing in addition to testifying or in lieu of thereof. If you wish to testify, please sign in at the table by the door and provide a business card to the committee secretary. Just as a reminder that when testifying, please turn on the microphones on and off to speak. And then we have listeners and viewers in Las Vegas and online and recording this meeting as will be available on the legislature's website later. And looks like Senator Wynn has arrived. And a reminder, all those to testify pursuant to NRS 218E, it is unlawful for a person to knowingly misrepresent facts when testifying before a legislative committee. Okay. And then, of course, and finally, please turn off any electronic devices. So to begin today, we will have a presentation from DPBH. So today we are fortunate to have one of our very good leaders, Ms. Julia Peak, who is a Deputy Administrator for DPBH, who will present on the governance in Nevada. So please proceed when you are ready, ma'am. And before you begin, I just want to thank you for your service throughout the COVID-19 pandemic. I think many of us really do appreciate the work that you have handled and the graciousness that you have provided our state, and I think today's hearings will reflect that. So please proceed when you're ready.
Thank you so much for that and for giving me time to talk about public health governance and later present SB 44. Already screwed this up. How do I get it to go on there? Is the sheet on there?
It will be up there.
Perfect. Look at that. Okay, so we're going to talk briefly about public health governance. So public health governance is a way of classifying a public health structure within states, and it's also a way for us to understand what other states are doing as well. This affects how the public health services are funded and delivered. It defines roles and responsibilities and authority across state and levels of government, and I did provide a handout that kind of summarizes this. And that's available. So I pulled out right there decentralized or largely decentralized. The exhibit shows the map. Nevada, as you can see, is only one of 2 states that are noted in green, which means largely decentralized. So what's that mean? So largely decentralized means basically that much of the services provided to our residents are done by local employees versus state employees, which would be found at a centralized health department. Mixed structure is there's a combination. That's a really rare type of government. And then a shared or local, again, is where they have a combination. Again, more rare than having a fully decentralized. So at the state of Nevada, we have the Division of Public and Behavioral Health. We are considered the state public health agency or state public health authority. We do have local public health agencies as well. Carson City Health and Human Services, they are considered a local public health agency serving the county. Southern Nevada Health District is an urban health district, Washoe County Health District as well, and we have our very newest Central Nevada Health District. That is our first rural regional health district, so we're really proud of the work that they have done. Much of the work in public health around governance is shown within NRS 439. I've provided some excerpts that I think are helpful. It's a much larger section. But what we have at the Nevada Division of Public and Behavioral Health, we have a state board of health that oversees much of the processes done by our division. That includes the regulatory processes and other things. We have a chief medical officer who oversees the agency and provides us guidance from policy to basic public health services. We have county boards of health and county officers that are defined, also health districts and district health officers, and city boards of health and health officers. You'll also find in NRS 439 discussion on assessments. We used to get state general fund before the Great Recession that supported tuberculosis, STD services, and a few others. During the Great Recession, some of that money was pulled back, and within NRS assessments started to be charged. And so those assessments, as defined here, the counties where we serve as their health authority, they contribute to the services we provide related to nursing, environmental health, infectious disease control, and others. So what's local governance look like? And this is common as most of our counties have county governance. So they must have a county board of health. They must have a county health officer. If that's not appointed by the end of January after every election, our chief medical officer has to appoint that position for the county. They must oversee sanitary conditions for the county and adopt regulations. Those regulations are ultimately taken to the Board of Health for approval. And they may choose to do other things as noted here. So there are several options for counties as they look at how they want to deliver public health services in their community. What the Central Nevada Health District just did, which I can highlight here, is they went forward to remove the assessment, so they're no longer paying the Division of Public and Behavioral Health for those services come July 1st. So they had to request that approval from the governor and then present that consideration to IFC. That was all approved, and then within 6 months, they no longer need to contribute that. And basically what they're saying is they're putting a plan forward saying, we will do this locally to the level that the state was doing prior, or better, ideally. One of the things that we're really supporting, at least as a goal state, is looking at regionalization, especially for our rural counties, because much of the work in the rural counties is done by the division. So regionalization is a benefit for our rural counties for many reasons, but one that is most important is the investment. We have really limited public health dollars, and so when you look at a single county, just based on their per capita in the rural region, it would be really difficult for them to have a big workforce to support. One single person could be funded out of 5 different grants, and so much of their work would be reporting, not actually providing public health services. But when you regionalize, and Central Nevada Health District did this, you have much more funds so you can hire the experts needed. One of the things that must happen is you have to agree to dissolve the county boards of health and then dissolve the county health officer position as well to ultimately go up to a district board of health. The district board of health looks slightly different, and it has slightly greater duties. So we do have 2 longstanding health districts in the state, the Washoe County Health District and the Southern Nevada Health District. I'm sure they've presented in front of your bodies before, but our newest member, the Central Nevada Health District, again, is our first rural regional health district. They were established on December 3rd, and this is Churchill, Mineral, Pershing, Eureka, and the city of Fallon. And then Carson City Health and Human Services, I'll say our first accredited public health agency in the state. They've done a really phenomenal job over the years. They're not considered a health district, but they are a health authority, and much of their work is done through the delegation that I mentioned earlier. They also serve the Quad County region. You may have heard it quite often if you live locally. That's Carson, Lyon, Douglas, and Story County. They provide this oversight through delegation by our chief medical officer and also grant funding. So we specify within our funding that they must serve the counties to the level that we would. In order for this Quad County to become a rural regional health district, they would need to dissolve their local boards and then again have one single district health officer. So there's challenges. There's specifications as to what these health districts look like based on population size, not atypical within our statute, but that is something you must consider. And then also, at least for the Central Nevada Health District, one of the challenging things was noted within our statute is you have to be an adjacent county to be part of that partnership. And what we found in forming this Central Nevada Health District is it really matters more which counties have like minds about how they would like public health services to be delivered versus you happen to share a border. So you'll see today in SB 118 that the word adjacent is up for consideration to be removed, simply to allow counties who choose to regionalize to work better together. So they also have to have all of the bodies, again, choose to dissolve and then approval by the Board of Health. So a couple of references that I've provided, just some resources that talk about governance more broadly. If you're interested to see how other states are organized or the benefits and challenges of each, I've provided those as references. And then my contact information and acronyms. Happy to take any questions if you have them.
Thank you so much, Ms. Peak. Committee members, questions? Senator Nguyen.
Thank you for that. I just have a question. I saw that hyperlink to other states and how they organize. Are there any that do it better that I should look at?
Julia Peak for the record, through you, Chair. So I wouldn't say better necessarily, but I'd say maybe more mature for what Nevada would like to look at. So most of the states in the West are fully decentralized. So my opinion would be in the next decade, if we could get fully decentralized, there's value in that, meaning that most of the services our residents receive would be from a local employee versus a state employee. Great benefit in that. I think the reason that many Western states do this would be just sheer geography. You know, when you have local employees, they know the resources locally much better. But there's a variety of reasons, I'm sure, that the states around us have chosen to do that.
Thank you so much. Did you have a follow-up, or are you good?
No.
Okay. Anyone else? I don't think we have any other questions. Thank you so much. We'll go ahead and move on to the hearing on Senate Bill 118. So I will go ahead and open the hearing on this bill, which provides provisions relating to public health. I do have a few remarks before I kick it off to some of the presenters. So I think it's important. This is the first of the few public health bills that we have this upcoming session. I think it's important to curate for you all as to why they're coming forward and what we kind of agreed to during the interim. So the bill with Senate Bill 118 was requested by the Joint Interim Standing Committee on Health and Human Services, which heard testimony from state and local health authorities over the interim about the continuing of the critical need for stable funding and structural support for public health in Nevada. Senate Bill 118 addresses that issue by creating a dedicated account in the general fund for the purpose of improving public health in our state, and it also promotes increased access to public health resources by allowing non-adjacent counties to create a health district. Today, for this bill presentation, we have Megan Kamlasi, who is from the Center for Public Health Excellence. We also have Caleb Cage to represent the Central Nevada Health District, Mr. Kevin Dick from Washoe County, and then Dr. LeGuin from the Southern Nevada Health District. And just to provide a brief background as to what we've done during the interim. So last year we passed Senate Bill 209, and that bill was passed from the COVID session. And, you know, during that moment in time, as we were trying to figure out as to what we can do to improve our public health system, the interim study required the interim HHS committee to look at a few things. One was to examine the public health infrastructure in the state, the strengths and weaknesses that we observed, and how local governments could respond better in future public health emergencies. We also wanted to consider recommendations for increased funding for public health, examine the health and economic impacts of the pandemic, the long-term impacts on the healthcare system and the workers on the front lines, and of course the challenges and benefits of creating a public health service corps in Nevada. And we held various roundtables throughout the interim regarding what our public health system could look like, and we engaged with many stakeholders with regards to what legislation could potentially be. And so that's pretty much what we have today. That's one of the first bills. And so I'm going to go ahead and turn it over to Ms. Kamlasi so you can go ahead and give a bill overview, and then we'll give it off to the other presenters. So thank you. Ms. Kamlasi.
Thank you so much, Senator Doñate, and thank you, Chair, for inviting me to be here. My name is Megan Kamlasi. I am the Associate Director of the Center for Public Health Excellence within the School of Public Health at UNR, and delighted to be here to present Senate Bill 118. I have this presentation. I don't think it's quite in presentation mode, but hopefully you will be able to see the slides. I don't know how to get it bigger. But there we go. So as the chair mentioned, this bill came out of the Interim Committee on Health and Human Services and really was a result of all of the time and effort that committee members and stakeholders put into the SB 209 study. And so comes from a place of lots of study and evaluation of what happened during the COVID-19 pandemic. But before we get into the bill, I do want to just take a step back and talk a little bit about what we mean when we talk about public health. The focus of public health is really on keeping entire communities healthy. It's not on individual health care. So whereas we or our families go to the doctor or a hospital to seek assistance with some sort of healthcare need, public health and public health practitioners and services and systems work to keep entire communities healthy. The goals are really to understand what causes people to get sick and die, and then to develop and implement strategies to prevent those things and increase or promote interventions that keep people healthier. The public health system is comprised of governmental public health agencies at the state and local levels, as well as community partners, and those may be public, private, or nonprofit. The challenge for public health, and I think something that's critical to highlight, is that when public health activities are working, we don't necessarily know or hear about them. We take the accomplishments of public health for granted, and many of us may not have even been familiar with the term prior to the COVID-19 pandemic. Public health as a field has existed for more than a century, and it has grown and evolved as science has advanced, but it's something that happens in the background, and it's generally invisible. Even though it's invisible, it has a real impact on our daily lives, whether we realize it or not. And so just want to highlight the fact that there are ongoing efforts to keep communities and people in Nevada healthy, whether we see them on a daily basis or not. I think one of the toughest things to wrap your head around when we're talking about public health is that it involves so many things. And so on this slide, you have public health A to Z, and these are just things that public health does to keep people healthy. Pulling a few off the slide, disease surveillance and investigation, we may all be familiar with following the COVID-19 pandemic. Food safety is super important in Nevada to Nevada's tourism industry. If you think about the large events that happen in Reno, the rib cook-off that happens, public health is there, Washoe County Health District is there, ensuring that the tons of food that is provided to the public is kept at safe temperatures and does not result in mass sicknesses or visitors coming to Nevada and getting sick. So super, super important public health emergency planning and preparedness. We need to be ready for the next crisis. You can go through this slide and see all of the different things that public health does. And there are a few of these things are things that you may actually see, public awareness campaigns related to tobacco or vaping, but the vast majority really happen in the background. So the problem that SB 118 aims to solve is really twofold. The first is public health funding, and funding is critical to public health infrastructure, workforce, and technology. The second piece relates to public health administration, which Ms. Peak just discussed, and that is that pursuant to NRS 439.370, counties have to be adjacent to form a health district. So a small change that could make a big difference in Nevada. Nevada currently spends the least on public health per person of any state other than with Wisconsin, with which it ties. And even though state and local governmental public health agencies play a critical role in ensuring the safety, security, and prosperity of local communities, they have been consistently underfunded and underfunded for decades. The overwhelming majority of public health funds are obligated for a specific purpose, and the overwhelming majority of funds come from the federal government. This means that the state and local public health agencies don't have flexible funding to use when a crisis arises. So funding is directed to chronic disease prevention or cancer or something related to asthma or maternal child health. But what happens when the next COVID-19 hits? What happens when this COVID-19 hit? What happens when Zika happens or when there's another outbreak of some disease that we don't yet know about? Funding isn't available, and so it impacts their ability to react because they do not have flexible funding. And finally, just to note that some of the most vulnerable populations and under-resourced communities feel the biggest change or feel the biggest impact of changes in public health funding. Research shows that $1 invested in public health results in a return on investment of more than $5. And so investing in the public health system is an investment in the health of Nevadans. This just gives you an idea. It's the public health budget of DPBH for this coming biennium. 3% of this funding is state general fund, 57% is federal funds, and then 40% is other. And so you see there's about $19 million of the general fund that goes to public health, and there's been an increase in state funding to public health in recent sessions for specific purposes. So that's something to celebrate, and what would be great to see in the future is additional funding going to public health that provides that flexibility. The public health workforce is another piece that this bill aims to address. A 2021 analysis looked at the gap in the existing public health workforce, and across the nation, an additional 80,000 full-time staff are needed to provide foundational public health services, which are a defined set of services that only governmental health agencies or public health agencies provide. 54,000 of those nationwide are needed in local health departments, and 26,000 are in state health departments. And we've seen that in Nevada as well. We are experiencing a public health workforce shortage. And then finally, this report also showed that there was a 15% decrease in staffing due to the lack of consistent investment in governmental public health services. So the lack of funding really affects the ability to staff up public health agencies, and public health practitioners are really the core people who provide public health services. So really challenging to provide adequate public health without the workforce needed. As we've seen with other workforces in the COVID-19 pandemic, the shortages that we experienced were exacerbated by the pandemic. A survey of the national public health workforce indicated that nearly 1/3 of the workforce is considering leaving their organization in the next year. Half of those are considering leaving due to pay, 41 due to work overload and burnout. If you think about the people who were responding to the COVID-19 pandemic day in and day out, they were dealing with a lot in a short period of time, and they continue to work really hard to keep people healthy. And then finally, 37% are thinking to leave due to stress, and almost 40% as a result of the pandemic. The other piece of public health infrastructure is technology and data modernization. The field of public health is data heavy, and it relies on the ability to collect and share data quickly. But unfortunately, a lot of public health agencies have old and outdated IT systems, systems that don't talk to each other. There's a lack of interoperability, and so data modernization is a focus for national, state, and local public health agencies. The other problem, in addition to infrastructure and funding, is this public health administration piece, which you'll hear more about from Mr. Cage in just a minute. But essentially, there's challenges for the current Central Nevada Health District because there's one word in statute that says that counties must be adjacent to each other, which impacts the ability of the state move toward that decentralization of public health services that may be better for the people of Nevada. So just leave you with a couple of thoughts about why Senate Bill 118 is important. The health of your constituents and the health of the economy really depends on having strong public health systems. These are the services and systems that keep our communities safe and healthy during normal times, and that are equipped and have the resources to successfully respond to emergencies when they happen. Also, healthy people are productive people, and productive people contribute to a stronger economy. Healthier workers are more likely to show up for work, to be productive when they're at work, and to advance through workforce pipelines. In addition, improving health at the population level can reduce state costs. I think you heard from some of the Medicaid managed care organizations on Tuesday, and some of them presented what they are doing in terms of community health initiatives. Community health is population health, is public health, and they are investing in those initiatives because it keeps the people they serve healthier, but it also saves them dollars. It makes it cheaper to provide care to people who are healthier, who get services on the front end, whose health conditions are prevented or treated earlier on in the process rather than waiting until they're worse. So if Medicaid managed care organizations are implementing public health measures to save costs, it seems only reasonable that the state would do the same across the entire state. And then finally, in addition, investing in robust systems that essentially detect, prevent, and address public health threats is more cost-effective than responding to public health emergencies. So money invested in public health now makes a state that's more prepared and ready to respond to the next public health emergency, rather than saving that money and trying to address an emergency when it happens. So if you look at the bill, I'll quickly walk through the sections. There are a couple of definitions at the beginning, including a definition of health authority, which we'll talk about in a minute. Section 5 requires an account to be created in the state general fund to be administered by the administrator of the Division of Public and Behavioral Health within DHHS, and the account is for the purpose of improving public health in Nevada. Section 6 requires money to be allocated to each health authority annually based on the population under its jurisdiction, and it requires health authorities to evaluate the public health needs of residents, prioritize the needs, and then expend the money they're provided in order of priority. Section 7 and 8 remove the requirement that 2 counties must be physically adjacent in order to create a health district. And then Section 9 appropriates $15 million to the account for public health improvement from the state general fund each year of the biennium. And I would just note that the $15 million figure came from an approximation of if we were to increase public health funding for per capita, it would be $5 per capita. So $5 per capita times 3 million people is $15 million a year. And if we increase public health funding in Nevada by $5 a person a year, we would move from tying for 49th in terms of rankings up to 44th or 45th. So is it a huge jump? No. But is it progress? Absolutely. And so those are the key sections of the bill. An amendment has also been proposed, and so that is available on Nellis. And the first part of the amendment would require health authorities to submit to the director of the Legislative Counsel Bureau to be transmitted to IFC a report of how the money that they received was used, and that would have to be submitted no later than 45 days after the end of the fiscal year. And the report is to include a description of the process that was used to evaluate the public health needs of residents in their jurisdiction, as well as a description of how the level of priority was determined. And the goal here is just to build in a little bit of accountability so that the legislature has the ability to see how and why this $15 million is appropriated. And the second proposed amendment is to revise that definition of health authority to provide that a health authority means the district health department or in a location not part of the district, the Division of Public or Behavioral Health or its designee. And so this is getting at the point that Ms. Peak mentioned. Carson City Health and Human Services does not currently fit into the definition of health authority as outlined in the bill. This amendment would allow money to funnel through DPBH to Carson City Health and Human Services for the purpose of this per capita allocation. So that is it from me. I'm going to turn it over to Mr. Cage to talk a little bit more about the adjacent piece.
Good afternoon, Chair Donyate and Vice Chair Gwynn and members of the committee. My name is Caleb Cage. I'm the interim administrator for the Central Nevada Health District. I'm going to speak briefly about the importance of Sections 7 and 8 of this bill, although the overall bill is, I think, extremely important, and we appreciate your leadership during the interim in bringing this legislation about. Central Nevada Health District is Nevada's newest health district. It is also Nevada's first rural health district and first health district made up of multi-county communities. It is made up of Churchill County, Pershing County, Mineral County, and Eureka County. It also includes the city of Fallon, which is the county seat of Churchill County. As you heard Deputy Administrator Peak talk about, there was a long process involved in establishing a new health district, and that process was carried out through 2022. Where the communities who were involved received support from the governor to pursue this, received approval by the State Board of Health and the Interim Finance Committee in order to make all of the administrative changes necessary. They also passed ordinances that abolished their local health boards and interlocal agreements that established the function of the Central Nevada Health District, and will be fully operational and underway on July 1st, although we're working aggressively right now to make sure all of the pieces are in place in order to provide services on July 1st. The one part of the existing law that prevents the the complete governance structure of the Central Nevada Health District is addressed in Section 7 and 8 of this bill, and the word adjacent, as Ms. Kamlasi pointed out. Currently, 3 of the counties that are in the Central Nevada Health District are adjacent. However, Eureka County is not. Lander County separates it from Churchill County. So it is joining, or has joined, the Central Nevada Health District through an interlocal agreement. So those services are provided. That's going to be fine as far as operations are concerned, but we need to fully make them a member of, and they would benefit from, and the district would benefit from their full and complete membership, and not the interlocal agreement that is there as well. Also, if health districts are indeed an ambition for the state to continue to pursue in order to serve the needs of rural Nevada, the language that is currently in the statute requiring adjacent counties or adjacent to counties to be adjacent in order for a health district to be established, then that's going to limit some of the progress in the future. And so removing this word would not only be a benefit to us and our operations, but it would also allow other counties to pursue their own relationships as they see fit, and to stand up these very important health districts within their communities as well. So that's the end of my remarks, and I'll take questions after.
Good afternoon, and thank you, Chair Doñate, for the opportunity to assist in introducing SB 118. I'm Kevin Dick. I'm the District Health Officer for the Washoe County Health District, and we recently had the opportunity to work with the National Public Health Foundation to assess our staffing adequacy to provide foundational public health capabilities and service areas. Those capabilities and areas are things like equity, community partnerships, communication, policy, emergency preparedness, communicable disease control, chronic disease and injury prevention, environmental health, maternal child health, and access to clinical care. These foundational public health services form the foundation that every public health department must have to be able to adequately support public health programs and services needed by the community. Those community need programs require additional staffing and are designed to meet community-specific needs and are not considered foundational or part of the foundational workforce assessment that we've conducted. Following the Du Beaumont Foundation work and the report Staffing Up, and that's the report that provided those workforce numbers that Ms. Kamlasi included in her presentation, we found from that additional public health workforce staffing is required nationally, and we utilized a calculator tool developed by the University of Minnesota based on results from foundational public health services workforce assessments that have been conducted in a number of states. And we use that calculator to assess our current staffing against what the calculator tool would estimate that we need for a community our size. We looked at each position in the health district and how many FTEs were invested in the different foundational areas that I ran through. We found we were 24 FTEs short for a community of our size, just looking at the foundational service areas, so 24 full-time positions short. And that was not accounting for our other staffing needs that we would have to adequately provide more community-specific programs. So this is the result of underfunding and understaffing of public health that has left us so poorly prepared to respond to the COVID-19 pandemic. If we'd had the Public Health Improvement Fund, if we had the fund, we could use those funds to help fill that gap. For instance, by supporting our health equity efforts, working to address the health disparities that were so starkly demonstrated and amplified by the COVID pandemic. The assessment also showed we needed more epidemiology and disease investigation staff. And we could use public health improvement funds to retain some of the staff that we're going to lose at the end of the COVID-19 grant funding. During the pandemic, we had our communities clamoring for information on how the disease was impacting different populations and where outbreaks were occurring. Ms. Kamlasi, I think, talked about the IT system. I think that's flattering. My IT system was an Excel spreadsheet trying to provide numbers that did not meet the expectations of what the community was looking for. So we could use public health improvement funds to address our inadequate data platforms and provide more meaningful data to inform ourselves and our community. And during the Great Recession, we had to eliminate our home visiting program that was for at-risk new mothers and their infants. It was not an evidence-based program. And if the Public Health Improvement Fund was established, that would allow my board to consider using the funds to establish an evidence-based nurse-family partnership program like they have in Southern Nevada. So Ms. Komlasi mentioned, and was made clear during the pandemic, public health is essential to our economy and our lives. SB 118 will provide the type of flexible, non-categorical funding that is so essential for our health district to be able to provide the programs and services that are vitally needed for our community. Thank you.
Thank you so much. Ms. Kamlasi, did Dr. Ligon want to provide comments as well, or?
I'm not sure, Megan Komlasi, for the record, if he's online. Oh, there he is. Yep,
Oh,
there you
yes,
go.
I am. Thank you.
Please proceed.
Sure, thank you. Okay, let me, can you see my slide there?
We do not.
Okay, I will do again.
There you go.
Okay. For me, again, District Health Director, Southern Nevada Health District. We want to talk very briefly about
Dr. Ligon, can
our-
you speak a little bit louder or closer to the mic just so that we can hear you appropriately?
Okay, what about now?
A little bit
That's
better.
the most I can.
You're good.
Okay, thank you. Thank you. Okay, well, we just wanted to show, for example, this year budget for our organization, which is about $180 million, which looks great, but it has a high risk because of almost 60% of our budget is federal grants. And as we already know, federal grants might disappear any given time. And just to give you an example, today we were analyzing our public health lab situation where we have a total of 46 employees, and 35 of those employees are supported by a federal grant. So we have huge concerns about how to sustain that workforce 2 years from today if those funds disappear. I have a list of different interventions that we feel that are needed in this community, and this is not all inclusive, but it's a list of different projects. Those projects go from the need of enhancing diagnostic capabilities here through the lab, also related to behavioral and mental health needs, maternal and child health, as well as health equity and adolescent health needs, and also the need for expanding, enhancing our infrastructure, because our organization has grown dramatically in the last 3 years. Just to let you know, for example, in 2019, we have about 490 something employees. Today, our workforce is over 100 employees. So the need for expanding our capacity in our facilities is evident, but also the need to be able to keep most of that workforce once the federal funds disappear is another challenge. Some of those projects are related to, for example, having a team working on socioeconomic depressed areas to enhance access to care, facilitating linkage to primary and behavioral health services in the community. Another project is increasing our work with the homeless community and making sure that we establish a linkage to primary care and mental health services for them. Also taking the experience of a current project we have, like this federal grant we have for overdose to action project, which is
Dr. Le
addressing.
Guin, not to
Yes.
not to cut you off, but I think in the interest of time, I think there is support from this committee, and I just want to we appreciate your projects and your interest in this, but I think essentially what I'm trying to say is I think we're pretty much ready for the next stage of the bill. So
Okay, well,
yeah.
that's great. I just wanted to share some ideas of needs in the community, and again, I'm sure that there are across the state. So
Thank you so
that will
much,
end my
sir.
presentation.
Yeah, I really
Sure.
appreciate it. Okay, let's go ahead and
Thank
we'll
you.
take committee questions. I do want to redirect you to review the amendment that is as part of the exhibits for this meeting, but committee members, any questions? Senator Stone?
Thank you, Mr. Chairman. Thank you to the panel for the great presentation. Ms. Peak, thank you for your endurance during the pandemic and trying to keep us all healthy. I looked at your pie chart where you showed what the governor's recommending in the 24-25 biennium, 3% general fund, 57% federal. You got 40% other. Can you talk about the 40% other is?
Yes, I'm going to let Julia Peak come on up and provide a little more detail on that.
Thank you, Ms. Peak.
Thank you. Julia Peak for the record, through you, Chair. So that other could be fees. It could be the assessments that I talked about earlier. The largest portion of that are the funds that we have received from our governor's finance office through the ARPA fund. So they are considered federal, kind of, with a caveat, and that's why we put them under other, because they are a transfer from another agency within state government.
Okay. You know, often your budget is kind of a reflection of the values of your organization, or at least the values you're trying to strive for, and it's very concerning that we're kind of at the bottom of the heap as far as investment and in public health funding. Have you looked at other states, and I mean, are they receiving more federal funds than we are? Are they contributing more general funds to their programs? What are we doing that isn't funding public health appropriately in Nevada?
Julia Peak for the record, again, through you, Chair. So we actually rank relatively well for federal grants. We often apply for competitive grants, and we have won some of those. For example, we won a competitive award looking at Alzheimer's disease in public health, kind of a new approach to looking at that with that lens. So we do okay for federal grants. We certainly try to go after more. In some cases, we're not competitive because they have in mind already what states they probably want to fund. Where we find the most efficiency is in just state funding. That's where you see the biggest difference between us and other states.
Okay, and then it was mentioned by more than one speaker about the antiquated technology that we have in the state. I'm hearing that not just in your agency, but in other agencies as well. Does public health have a capital improvement plan to kind of see the endpoint of where we want to go and what's it going to cost us? This is a struggle, and this is not for Nevada, this is a struggle for other states too, but technology can make us run more efficiently and can lower the cost of delivering the service to people and maybe expand those services to even more people. So what do we need? Do we have that plan, and if not, how do we get there?
Julia Peak for the record again, through you, Chair. Great question. And that's probably been one of our biggest struggles because we have so little funding. To invest in an IT system is tough because we really need humans to do the job. But as you mentioned, and for an example, when we were having staff do data entry from fax machines, when we were getting COVID cases versus actually getting the COVID cases and investigating them, that's where the problem was very apparent. But it goes back to funding. Most of our funds are categorical. What I can say that we're very excited about is our federal partners, primarily through CDC for us. They're funding some large data modernization projects. The grant that we have right now is for 5 years. Hopefully they'll continue to do that because modernization is continuous for these IT systems. So we're going to be doing some modernization with those, but it's expensive, and we do need to hire consultants and contractors to help us with those. So that money will only get us so far. But at least we have something. Prior to COVID, we had nothing.
Have we investigated other states that approximate our population to find out what technology they're using? Is it off the shelf, or I've come to the conclusion that every state doesn't need to have its own unique software system that could be very, very expensive when you could modify a off-the-shelf program that maybe works in another state.
Senator Stone, I'll answer that question. Hang on tight. We have more presentations later on in the session on,
Sure.
and as my favorite phrase, I have a plan for that. So
Thank you. I love it.
We'll talk about it at a later date. We have a statement from Senator Titus. So.
Thank you. I actually have a statement and question. I'll go with my question first. Just looking at the amendment, I just want to get some affirmation that the folks involved feel they can do this report within 45 days after the fiscal year. I'm a little concerned that is that enough time to get that report done, since not uncommonly, especially in the healthcare realm, it takes a long time to get the bills. And I know, Mr. Cage, you've been in the fire EMS and departments, and you know about billing and how long it can take to get financial square. So I'm wondering, can you get a report no later than 45 days after the end of the fiscal year, which the money was received?
Megan Komlassi for the record. Thank you, through you, Chair, to Assemblywoman Titus, or Senator Titus, sorry. The amendment proposes to submit a report that describes the process used to evaluate the needs of the residents, as well as how the level of priority was determined. And so at this point, it doesn't explicitly provide, require a definition of where, how much funding was appropriated to each priority. That could be included, and then the deadline extended, but essentially the bill currently requires health authorities to say, this is how, or to evaluate the needs and then describe how they're prioritize those needs. And so this is essentially having them explain their thinking and how that money is allocated.
All right, because I'm reading it says a report on the use of the money received no later than 45 days after the end of the fiscal year in which the money was received. And so I just wanted to make sure if that's the understanding, that it's just the conception of what you're using and how it was allocated, not really how it was spent, because I worry that that's not enough time.
Julia Peak, for the record, through you, Chair, to Senator Titus. It's a great point, and I'd say we typically with federal funds have a 90-day closeout period because we are trying to navigate those final expenditures. So as far as actual spending, 90-day consolidation period seems to make sense. However, as part of the funding that we want to keep at DPBH, we wanted to have an evaluator hired to look at how all of the counties are using these funds because it's necessary and appropriate. And so what that evaluator could do is we could, for example, develop a dashboard. If it's you're hiring a nurse, well, how many clients did that nurse serve? So hopefully we're looking at this in real time, over time. So when it comes to that closeout, hopefully we can give you some statistics. Financial closeout, again, it's a good point, could potentially be 90 days like our federal partners use.
Right, that's what I would like to see it mirrored with our federal partners and change it to 90 days unless there's Mr. Chair, just having the experience of the healthcare world and delay in payments and all of this stuff, 45 days is a really narrow amount of time. So just putting that out there. And the next thing is my comment. And I know that there are people in this audience who have worked literally hundreds of hours putting this rural health district together, and just want to acknowledge how the folks got it to happen, how they cooperated, and how it's amazing how, you know, some small group of people can really move a lot of ground and accomplish things. And the COVID was what really brought it to the forefront. It's been an issue for a long time, but thank goodness they stepped up, and I'm very proud, especially of my Churchill County folks, to make this happen, because they're driving, really have been the driving factor with this. Also wanted to get on the record, there's a reason that we're changing the language, and they don't have to be adjacent or contiguous, and then that way it still allows for the independence and just some clarity of that county in the middle that didn't want to be that still wanted a home rule, so to speak, and wanted to take care of themselves. They'll still need some state assistance. So just because we move forward with this doesn't mean that all counties will be subject to these kind of formations, and just wanted that to be on the record, and have to have an affirmation from you that is still up to the counties to be be able to do this?
Julia Peak, for the record, you're absolutely correct. This would make it easier should counties choose to become a health district, but there's not a mandate that the state would no longer offer services on their behalf.
Thank you so much. Any other comments or questions? Don't see any. Let's go to the testimony. At this time, I will go ahead and open testimony in support of this bill. So we'll start with testimony in the physical locations, and then for those who are called in, see quite a few folks in Carson City. So we'll begin. Just remember that I will cut you off after 2 minutes. So please begin.
Mr. Chair, members of the committee, for the record, Alejandra Rodriguez, Director of Government Relations for Nevada System of Higher Education, and she has longstanding support for public health and strongly supports SB 118. Thank you very much.
Good afternoon, Andrea Gregg. For the record, I'm the Chief Executive Officer of High Sierra Area Health Education Center. Over the last 15 years, our agency has prioritized providing internships and job placement opportunities for public health professionals, as well as recruiting public health students into our pathway programs. Through our prioritizing of public health and the integration of this diverse field into our programs, we've seen firsthand the positive impact that investing in public health infrastructure can have on our agency and the communities we serve. Our investment in public health professionals has had a profound impact on the quality of our outreach efforts, enabling us to reach even more people through the provision of our mission. By prioritizing diversity and inclusion in our recruitment and retention efforts, we've also fostered a more representative and effective public health workforce, better equipped to meet the needs of our communities. Public health is a key component of a state's healthcare workforce development efforts, and it provides the necessary foundation and support for healthcare professionals to effectively address the health needs of the population and ensure access to quality care, which in turn creates healthier communities and reduces the burden on the healthcare system. Nevada has the potential to revolutionize the health outcomes of its residents with an investment of approximately $5 per capita per year. Imagine the progress that could be made towards building an equitable and healthier society. By investing in public health infrastructure, the state can better serve its population and address the ever-evolving public health challenges that it's facing. And this forward-thinking bill will provide the necessary resources and flexibility to meet these challenges, ensuring that Nevada has a strong and sustainable public health system for years to come. Thank you.
Good afternoon. Sheila Bray, University of Nevada, Reno, for the record. The University of Nevada, Reno would like to voice support for Senate Bill 118. The University of Nevada, Reno is involved in public health efforts statewide, both rural and urban, with a first-hand look at the importance of prioritizing public health infrastructure and services for all of Nevadans. This bill would allocate funding to address individual community public health needs of utmost concern. We urge this body to consider support for Senate Bill 118.
Thank you, Mr. Chair. Michael Hillerby on behalf of Renown Health. As a nonprofit and the largest health system in the region, we are deeply committed to population health and are very happy to be here today to support this effort to strengthen our partner, the Health District. Thanks very much.
Thank you, Mr. Chair and committee members. Stephen Wood representing Carson City. We want to express our support for SB 118 with the amendment that was presented today. And we want to thank you, Mr. Chair, as well as all the stakeholders that worked on this bill. The director, to keep our testimony short today, of Carson City Health and Human Services has sent to the committee a list of all of the reasons why this will benefit the great work that she and her department do. So thank you.
Good afternoon, Chair Doniate, members of the committee. My name is Jimmy Lau with Ferrari Reader Public Affairs, representing Dignity Health St. Rose Dominican. St. Rose supported this measure out of the Interim Health Committee, and we'd like to put our support on the record for today's hearing. Thank you.
Good afternoon, Mike Brown. I'm one of the 7 board members for the District Board of Health, and we appreciate this bill coming forward. We're in full support from the board of the Washington County District Health Department, and we thank you for that. Thank you.
Hello, for the record, Vincent Guthrow. I serve as the Executive Director of the Nevada Association of Counties. We are in full support of SB 118. We believe this is a local-driven solution to local needs. We think the committee's consideration of this bill, and thank you for allowing flexibility for those counties in this sense. Thank you.
Hello, for the record, I'm Dr. Colleen Lyons. As a fourth-generation Western Nevadan and family physician in the Carson area for 30 years, I encourage the Nevada Legislature to fund a public health improvement account within the general fund for uncategorical use by the health districts and health authorities to the benefit of Nevadans. I am an advocate for an improved healthcare delivery system and have made a private study of the topic, along with joining forces with state and national organizations to work to improve health outcomes in America. We all know that America spends more on medical care than any other developed nation and achieves the poorest health outcomes in general, with Nevada ranking poorly on the majority of those among the states. There are many contributors to the expense of health care in America, but without a doubt, one of those is America's poor investment in public health efforts across the country, and Nevada's investment tied with Wisconsin at the bottom of the barrel. The U.S. spends approximately one-third as much as our other industrialized nations on public health and 2 to 3 times as much on medical care after the fact. Because we don't invest dollars, it costs us thousands of dollars in medical bills. Unfortunately, states and the U.S. taxpayer pay the majority, namely 2/3 of those medical bills in America in one way or another. Additionally, medical illness, injury, and chronic disease account for massive decreases in economic productivity and personal income. When it's really bad, medical disability taxes citizens even further. We need robust and sustainable public health efforts to save money and lives and to prevent illness and disability. Let's have Nevada get started in providing funds that don't require some outside entity to decide we need to apply for a grant and administer the grant to get something done. Thank you.
Good afternoon, Mr. Chair, members of the committee. Jeanette Bells on behalf of the Nevada Public Health Association. All I can say is what a great ROI on $5 per person. We strongly support. Thank you.
Good afternoon, Mr. Chair and members of the committee. Blaine Osborne, President, Nevada Rural Hospital Partners. We're here in support of SB 118. NRHP is a consortium of the 13 critical access hospitals in the state, 3 of which belong in the newly formed Central Nevada Health District. And we also have 1 rural health clinic in that district as well. So happy to support that section 7 and 8, dealing with the word adjacent. Likewise, happy to support our partners in public health with any investment in public health funding. Thank you.
Hello, Chair and members of the committee. My name is Emily Walsh, and I'm here today just representing myself. I'm from Reno, Nevada. I'm a constituent of SD 16, and I support this bill because of the creation of the public health fund from the general fund. My younger brother died a month before his 18th birthday from a very rare disease. And even though we then knew the disease was in the area, it was unable to prevent the death of another young man, this time 20 years old, not even a year and a half later. Mr. Kevin, I'm sorry, his name, spoke about the fact that they could hire epidemiologists with this money that is going to run out after COVID, and I am in strong support of that, specifically because in the case of these rare diseases that are public health issues, the nearest specialist, at least in hantavirus's case, is in New Mexico, and the treatment we don't even have in Nevada. We had to have a test and wait 7 days to even find out what had killed my brother. Hantavirus is actually present throughout the entire state and is more rural in nature, but both of the people who died in 2019 and 2020 were located in Washoe County. So I would just urge your support for this, and thank you for your time.
Thank you so much, Ms. Walsh. I think from the committee members, we appreciate you sharing your story. And let's go to anyone in Las Vegas or BPS, anyone virtually.
If you would like to testify in support, please press star 9 on your phone to take your place in the queue. caller, you may begin.
Hi, my name is Nancy Bowen, Nencybowen. I'm the CEO of the Nevada Primary Care Association. Good afternoon, Chair Denote and members of the committee. The Nevada Primary Care Association represents the state's 8 community health centers, also known as the federally qualified health centers. A key part of our mission is to identify and measure the impact of the work we do on the health of the communities. Public health data collected at the community level are crucial to the health center model. We are here to we are in support of Senate Bill 118, and our full written comment and testimony has already been submitted. So thank you.
Chair, there are no more callers in support at this time.
Thank you so much. Anyone in opposition? Don't have any. Is there anyone in Las Vegas or virtually?
If you would like to testify in opposition, please press star 9 on your phone to take your place in the queue. Chair, there are no callers for opposition at this time.
Thank you so much. And is there anyone in neutral? Anyone virtually?
If you would like to testify in neutral, please press star 9 on your phone to take your place in the queue. Chair, there are no callers for neutral at this time.
Thank you so much. I don't know about you, but I'm tired of being last in the nation. So let's close this bill hearing, and I think we have a statement from Senator Nguyen.
Hi, I'd like to, Chair, I would like move to amend as amended Senate Bill 118, but also a further amendment to change it from 45 days to 90 days. And so with those 2 amendments, I'd move to amend twice and do pass.
Thank you so much. Any seconded?
I'll second.
We have a second from Dr. Titus. Any questions on the motion to amend and do pass? All amend and do pass. No questions. All those in favor, please say aye. Aye. Any opposed? Motion carries to amend and do pass. I will sign that to myself. And we will go on to our next agenda item, which is we'll open the hearing on Senate Bill 44. This bill revises provisions related to dental and oral health care. So, Ms. Peak, whenever you're ready.
Julia Peak for the record again. Chair Doniante and members of the Committee of Health and Human Services, I want to thank you for the opportunity to present SB 44 today. I serve as one of the deputy administrators, as you know, for the Division of Public and Behavioral Health, although had the pleasure of overseeing the oral health program for many years. I'll provide an overview of Senate Bill 44 and then can answer any questions that you have. I just want to note that I provided as an exhibit, as background, that we at the Division of Public and Behavioral Health had a letter of intent from 2019 by the legislature to secure sustainable funding for the program. And that included the salaries of the dental health officer and state public health hygienist. So this bill helps us ensure that we can keep the commitment to have those positions and oversee the state oral health program. SB 44 is a bill designed to improve the hiring and retention of these 2 positions, as well as streamline the management of the Nevada oral health program. If passed, this bill would take effect on July 1st, 2023. To walk through this bill briefly, in sections 1 and 2, we request the changes to allow the director to appoint the state dental health officer and state public health dental hygienist. We also request the reference for division to be replaced with department. Please note that we do want to retain the information related to residency and education, training, and experience. However, we'd like the licensure requirements to be permissive for both positions to allow greater ability and flexibility to recruit and retain the individuals in those positions. This will mimic the requirements of our chief medical officer at the division in that position and ensure that we can still have opportunity and flexibility as we recruit. For both positions, we also request the removal of language that requires the position to devote their full time to the office and limit any ability to hold another business or vocation outside of that role. We have been challenged to recruit these positions based on the salary we have to support them. And then removal of this especially is important to the dental hygienist position because we only have funding to support that position part-time. Within sections 3 and 4, we request the removal of division for department as it relates to the oversight of the advisory committee. We request that the director, not the division administrator, appoint the positions to that committee. Within sections 5 and 6, we would like to replace division with department and administrator with director to oversee the oral health program. Section 7 and 8 outline the role of the Legislative Council and our department and agency to update NRS and NAC accordingly. That is a very fast summary, and I am happy to answer any questions that you may have.
Thank you so much. I will go ahead and entertain questions. Senator Titus.
Thank you, Mr. Chair. And thank you for the bill, which I do support 2/3 of it. I certainly am just fine with the moving and appointments and directors. I still have a hard time with not having them be licensed in the state of Nevada. You know, we have a bill, and I know our chief medical officer is not licensed, and I have issues with that. But we have made our attorney general mandated that he have a license to practice law in the state. So there is other agencies where the person giving the advice must be, for example, a licensed Nevada bar person, our attorney general. And why our dentist and our dental hygienist would not have a license it's just not something that I think is appropriate. I understand that you need to be able to hire folks. If you had the language that you could hire them while their application was pending, or that the intent was that within a year of the job they had to be able to get a license. I understand there's delay in licensure, but I have a hard time not having them licensed. And one of the examples I would point out is that they may not actually practice dentistry, but they're going to be asked for dental advice. They're going to be giving advice that people will then take to not to the bank, but that it's credible. And to be handing out advice and not be licensed to do that, I just have a hard time with that. So that's my issue with the bill. Everything else, good.
Thank you, Julia Peak, for the record. Again, this just allows us the flexibility. I'll say that our dental hygienist position, once vacated, was vacant for 6 months. Even worse, our dental health officer, when vacant, was vacant 18 months. This is a program of 2 people. And so when I lose 1 or 2 of those people, you don't have the program any longer. And so it's a matter of saying we'd give you the flexibility so that you at least have a program in the state for oral health, which we've been unable to do, and we have 1 or both of the 2 positions that support the program vacant. So I totally appreciate where you're coming from, and we would like it permissive, and we'll certainly recruit and try to get that for you all. But we also don't want to have a vacancy and not offer the service, because that is mandated that we run the oral health program. So your consideration is appreciated, but I certainly appreciate your opinion.
Thank you so much. Any other questions? Senator Lane.
So I have a question about, so the person, it looks like the person used to be full-time and now you're going to make them part-time, but I don't see anywhere in the bill how it quantifies the amount of time they're going to spend doing this, or who would monitor that.
Perfect. Julia Peak, for the record, through you, Chair. So it's based on funding, how much time we can devote those positions to the work. So it was approved that the state dental health director works full-time in the position. So he's funded at 40 hours per week or more. It's an unclassified position to work on behalf of the Medicaid. He's on an unclassified Medicaid position. The state dental hygienist, we use the Fund for Healthy Nevada, and we've only been able to support that position half-time. However, if we were to apply for a federal grant and get it, if we were to get funds from SB 118, as we just spoke about, perhaps we would make that position full-time and be able to support that. Your second question as to who oversees it, the state dental health director reports to the Medicaid administrator. The state public health dental hygienist was reporting to me.
Thank you.
Any other questions? I don't see any. We'll go ahead and move on to testimony. So anyone in support of SB 44 here? Please remember to state your name before beginning.
Good afternoon, and thank you for giving us this opportunity. My name is Karen Soley. I'm a registered dental hygienist here in the state of Nevada, and I'm speaking and representing the Nevada Dental Hygienists Association. We did submit our report, or our testimony to you also electronically today. The NDHA, which is the Nevada Dental Hygienists Association, unanimously supports SB 44. The existing statutory requirements have excessive and restrictive language that does not exist for other state positions. This limits the pool of candidates that may apply for the employment. The bill before you removes that restrictive language and would provide the department flexibility to consider a broader pool of applicants to ensure that we could get the best and most qualified candidates that could have the opportunity to be considered for this position. For example, consideration could now be given to retired clinicians, part-time clinicians, and disabled clinicians. The existing language has conflicting requirements for licensure and clinical practice. Updating this language would resolve conflicting language and align the requirements with the job roles and responsibilities. For example, the state oral health positions are administrative under the state Medicaid department and do not require clinical hands-on practice. The NDHA unanimously supported the bill language originally in 2019. The existing language has been problematic for many years. The bill language before you was included in 2021 legislative session as part of the large oral health bill that was vetoed by the governor. However, that language was not controversial. The language was supported by all leading dental and dental hygiene associations in our state and was passed by both houses with bipartisan support. The language in this bill reflects changes that are needed to adapt to the ever-changing healthcare landscape and to continue efforts to ensure that all Nevadans have access to dental care. The state oral health program plays a vital role in protecting, promoting, and improving oral health in Nevada, and we all know that oral health is integral to our total health. Thank you for your consideration of the proposed language that would bring the state of Nevada oral health program in alignment with what is needed for the future of the oral health of Nevadans. Thank you.
Good afternoon, Senator Donate. Eddie Abeliser on behalf of Tri-Strategies with the Nevada Dental Association. We are here supporting this bill and thank the department for bringing it forward. We echo the sentiments of our colleagues at the Nevada Dental Hygienists Association and their support and the need for the changes in this statute. I do want to identify a couple points of interest that also shows why we might want to have that licensure provision in statute. The UNLV School of Dentistry also does not have a mandatory licensure for teachers in that realm, and they instruct and engage with many students. There might be a provisional license. Some might operate without a license, but be a dentist nonetheless. And so we think that the position here at the state to find a competitive individual to do the job warrants that provision for both dental hygienist and state dental officer. Thank you for your time.
Thank you so much. We don't have anyone else here in the audience, so we'll go to Las Vegas or virtual.
If you would like to testify in support, please press star 9 on your phone to take your place in the queue. Caller, you may begin.
Hello? Am I on?
Please proceed.
Hello? Yes, Mercedes Maharis, Nevada Silver-Haired Legislative Forum, Senate District 3, and a Nevada chaplain. I have worked with prisoners and parolees since the end of the last century. I think that we need desperately licensed dental care providers in each of our major Nevada Department of Corrections institutions. Why? Because oral health is obvious and determines whether our paroled prisoners have a chance to be hired or not. If they are not hired because of having pulled teeth, and I will send you one major photo of a person that I worked with for a long time who could not get a job, could not get dental care, and he lingered, well, he didn't have a happy ending to his life. And I think that in the long run, lack of oral health and dental care inside our prisons is costing us an absolute fortune. It's much easier to give them the help that they need so that they can be hired and return to be taxpayers and happy people. Nobody can smile with missing teeth, and nobody wants to hire those with missing teeth. I invite you to go to the parole center and sit down and just talk to people and look at all the people whose mouths are lacking basic care. Please do all that you can to change this. It's gone on for 25 years. We need your help desperately. I do support your bill, and thank you for all you do to help others. You are truly blessed when you do so.
Chair, there are no more callers in support at this time.
Thank you so much. We'll go ahead and move on to opposition of this bill. Is there anyone here? We don't have anyone in Las Vegas and virtually.
If you would like to testify in opposition, please press star 9 on your phone to take your place in the queue. Chair, there are no callers for opposition.
Thank you so much. Anyone in neutral? Anyone virtually in Las Vegas?
If you would like to testify for neutral, please press star 9 on your phone to take your place in the queue. Chair, there are no callers for neutral at this time.
Thank you so much. Any closing remarks? Are we good? Yeah, okay. We'll go ahead and close the hearing on this bill. At this time, we will go ahead and proceed to public comment. So for anyone in the physical locations or anyone who has called in, we'll go ahead and open it up. Just please remember to do it for 2 minutes. We don't have anyone here. BPS, is there anyone virtually or in Las Vegas?
If you'd like to participate in public comment, please press star 9 on your phone to take your place in the queue. Chair, the public line is open and working. However, there are no callers at this time.
Thank you so much. So that concludes the order of business today. We will be having a meeting for the following week, so we'll post the agenda fairly soon. I might say before we conclude that I was heartwarmed to see the support for public health. I think that, one of the things that we've learned throughout the COVID-19 pandemic was, I think we all reflect, not just in this state, but nationally, that we could have done a little bit better. And it's bills like this that just remind me that if there's one more life that we could save with the right resources that we have, the fight will always be worth it. So we'll see how that bill goes as it proceeds through the legislative process. So thank you so much for everyone who joined us today, both virtually and here. And so meeting is now adjourned.